It is now my honor to introduce the didactic speaker of the day. I'd like to introduce Dr. Rosemary Wanjiru. Dr. Wanjiru is a medical specialist at the Kenyatta National and Referral Hospital, attached to the endocrine department, where she runs specialist clinics and supervises both undergraduate and postgraduate students. She has over 15 years experience, having practiced in major hospitals in the country, and has carried out extensive research on diabetes, hypertension, and associated risk factors, particularly in the urban slums. Dr. Wanjiru holds a postgraduate diploma in endocrinology and diabetes from the Queen Mary University of London, a master's in medicine in internal medicine from the University of Nairobi, and both a Bachelor of Medicine and Bachelor of Surgery degree from the University of Nairobi. Her presentation will take 30 minutes. So join me in welcoming Dr. Wanjiru. Dr.
Okay, good evening. Can you hear me?
We can hear you, Dr. Let me stop sharing so you can share your presentation.
Sorry?
Could I stop sharing so you can then share your presentation?
Yes, please. Unfortunately, for technical reasons, I don't know why you can't see my face, but I'm glad that I'm loud enough. Huh? Thank you for the kind introduction, and I'm very honored to be part of this.
Just go ahead.
Thank you. I'm very honored to be part of this dissemination of information that is very critical. This is critical because about 500 million of people in the world have diabetes, and majority of these are living in low and middle income areas. And even we have found that the prevalence has increased in slums. And the last study that we did in the Kibera slums, which is quite huge, we found that we had a prevalence of about 5.2%. And when the age group was increased to above 40 years old, the prevalence increased to more than 10%. So this is quite important topic, diabetes. My disclaimer is that the slide deck that I'm going to share is a collaborative effort that was done between the Ministry of Health, the Kenya Diabetes Study Group, KDSG, DMI, that is Diabetes Medical Information and Insemination, and I'm part of the KDSG and the DMI. And this was done so that we can be able to speak in one, give similar information rather than different information when we're called to give such talks. So this slide deck has not been prepared by Dr. Wanjiru alone. We were quite a number who prepared this slide deck. And so I will start off. The objectives of this talk, in slideshow. The objectives of this talk are to find what is a normal glucose metabolism, how is insulin produced, and what are the actions, what are the consequences of insulin deficiency, what are the role of the insulin antagonists, and finally we're going to look at the pathogenesis of diabetes. The outline will be similar to the objectives and will follow in the same manner. So when we look at normal glucose metabolism, we know that when we eat our food has got different subtypes where we have our carbohydrates, proteins, fats, and even the vegetables. And what happens is that the body breaks down these different types of food using enzymes into smaller units. And this food, carbohydrates, is broken down into glucose, proteins into amino acids, fats into fatty acids, and glycerol. And all these smaller units are able to be absorbed into the bloodstream through the intestinal wall. So we will come back to this later. And therefore, body usually requires several hormones for it to be able to utilize the glucose, the amino acids, and the fatty acids. And this is a very critical balance that is of the production of hormones that is required, because when you have the balance is not maintained, then you end up going into metabolic disorders. Therefore, you can either have an excess or a deficiency, both of which are detrimental to health. So for the glucose to be utilized, then the body usually requires insulin, which is one of the key factors that we're going to discuss today. So in patients who don't have diabetes, once we eat, our blood glucose is elevated in the body, and that stimulates the pancreas to produce insulin. Now, what the insulin does is that it will activate and attach to receptors which are found in the fat cells, in the liver, and in the muscles. And therefore, you'll find that the glucose is able to be absorbed by the and taken up by the muscle cells so that they can store that glucose as glycogen. The glucose will also be taken up by the liver and will be stored as glycogen again, and will be used also in the fat cells. And in that way, you're going to be able to have a normal blood glucose. Now, I've talked about hormones, and what are hormones? Hormones are chemical substances that are produced by a cell, and they do not act in the cell that they are produced in. They act in different cells. Therefore, they work as chemical messengers. And for them to work in those different cells, they operate by binding to specific parts of the cells that are called receptors. Therefore, hormones are usually very potent, and they're released now by the endocrine cells, and they have to be regulated in a precise manner so that you're able to balance these hormones so that you can maintain a good metabolic state in the body. So our key hormone today of discussion is insulin. The insulin is produced by the pancreas and is produced by cells that are called beta cells. The pancreas has got other cells that are alpha cells, and I will talk later on what the alpha cells do. And the pancreas is between the duodenum and the spleen. In a normal healthy person who does not have diabetes, usually we produce about 18 to 40 units per day, which comes to roughly about 0.2 to 0.5 units per kg body weight per hour. Now, in a normal person without diabetes, what happens is that about 50% of the insulin is produced whether you're eating or not, and it's called a basal insulin. That is the insulin that is produced between meals and at night. Then the other 50% is produced as a response to elevated glucose after a meal. Therefore, it's called prandial or bolus insulin. So 50% is basal, is not dependent on meals, and the other 50% is prandial, is dependent on the meals. So it's a very delicate process to maintain the homeostasis of glucose at a normal level. And you find that when you eat and you're high, your blood sugar goes up in the intestines and in the bloodstream, the pancreas is stimulated. It produces insulin from the beta cells, and that works on the adipose tissue, that is your fat cells, on your liver and your skeletal muscle, and maintains the blood glucose. If you do have a low blood sugar, then the pancreas again is still stimulated, and now the alpha cells is what are stimulated to produce what we call insulin antagonists or counter-regulatory hormones, and they work by breaking down the stored glucose, that is our glycogen, to elevate the blood glucose that was low. So that is in. So what are the actions of insulin? Insulin is responsible for both glucose, protein, and fat metabolism. So we will start with glucose metabolism. Insulin is usually secreted, as we said, in response to high blood glucose. And what it does is that it will facilitate the diffusion of glucose through the membranes of cells that possess the insulin receptors. And these cells are the skeletal muscle, the cardiac muscle, and the adipose tissue. It will also act in the liver so that we can store that glucose as glycogen, which is an inactive form of glucose. And this is usually used in times of hypoglycemia, that is low sugar, or in times when the patient goes into a stressful condition. So that we've already gone through. So in a normal person, Insulin, as I've said, acts to facilitate the uptake of glucose into the cells. Therefore, you can see this cell is very happy because it has energy, it's able to use it. But in a patient with diabetes, either because they will lack insulin or they have resistance in the use of insulin, that cell, because there is lack of insulin, is not able to take up that glucose. Therefore, it is an unhappy cell, it is energy deficient. That is the difference between a patient without diabetes and one with diabetes. What about insulin and protein metabolism? Insulin also promotes the transfer of amino acids into the cells and will enhance the production of proteins or synthesis of proteins, especially in muscle cell. And in lipid metabolism, it again stimulates the adipose tissue to synthesize and store the fat. And these usually are used when the body lacks the normal glucose. And that insulin in the fat tissue or the lipid tissue will prevent the body from converting energy from fatty cells or lipid cells, which can be dangerous because it can give you an acidotic state and helps you to be able to just use the glucose as a primary source of energy. So what are the consequences of lack of insulin? What happens is that you find that the blood glucose level will rise because you're not able to take up that glucose into the muscle and the adipose tissue to be stored as energy. And therefore, the body, the cells, as we have shown, lack an energy source. Therefore, the body has to get alternate sources of energy, and it will end up breaking down the amino acids, will break down the lipids, and what is produced is what we call ketones and hydrogen. And those ones are acidic, and that is what we call ketogenesis. And in patients who, like the ones who have type 1, who have absolute lack of insulin, you find them going into what we call diabetic ketoacidosis. Therefore, lack of insulin is quite dangerous, and that is what we try to avoid. The release of insulin from the pancreatic beta cell can be due to a response from various factors. The most important and strongest stimulus is usually an increase in plasma glucose after we eat, but we have other factors that can also release insulin. Chemicals like drugs like sulfonylureas, neuronal stimulation from the sympathetic and parasympathetic system, and hormonal stimulation from the gastrointestinal systems and other counter-regulatory hormones. How does a beta cell function? You find that insulin release is biphasic, meaning it has two phases, and there's a rapid first phase and a prolonged second phase. The rapid first phase takes about 5 to 10 minutes, and thereafter it is followed by a prolonged second phase, which usually lasts the whole duration of the stimulus. So it will last during, if it is food you keep eating, then it will last during that period. If it's a chemical that is stimulating, it will last that period. The half-life of insulin in the bloodstream is quite short. It's about 4 to 5 minutes. But when the insulin is bound to its receptors, then the effect is longer. This comes into play when we have critically ill patients and they are in the intensive care unit or the HDU and are requiring intravenous insulin. And that is why we usually say that when you're giving the intravenous insulin, when you stop it, you have to stop it after you have given the subcutaneous insulin about 30 minutes prior, because of this short half-life of 4 to 5 minutes. The beta cells usually respond to blood glucose that is about 5 to 9 millimoles, and above 9 millimoles, you find the hyperglycemia causes a toxic effect to the beta cells. So you find those patients who have had a very high elevated blood sugar for a long time, we say that they have glucotoxicity, and that is why such patients are usually put on insulin as an initial therapy for the body to be able to recover from that toxicity. I've been talking about insulin antagonists or counter-regulatory hormones. These are hormones that work in a different mechanism from insulin, and their effect is to increase the blood sugar. The insulin, the effect is to reduce the blood sugar in the bloodstream by uptake of the glucose into the various cells, but the counterregulatory hormones do the opposite. These hormones include glucagon, growth hormone, cortisol, and adrenaline. And the most important and initial one that is produced is the glucagon that is produced from the alpha cells of the pancreatic cell. Growth hormone is produced from the anterior pituitary. Cortisol and adrenaline are produced from the adrenal medulla. And they all work in different ways, but the end effect is usually to increase the blood sugar. So what they do is that they convert our inactive glucose, which is called glycogen, to glucose, that is glycogenolysis. They also activate conversion of the fats and amino acids into glucose, that is your gluconeogenesis. And these two effects eventually increase the blood glucose in the system. So they're very important hormones. When a patient goes into low blood sugar, those hormones are activated so that the patient does not have detrimental effects. Now, when we go to the topic of the day, the pathogenesis of diabetes, we know that we have type 1 diabetes and type 2 diabetes as the two major types of diabetes. Today, we are not going to go into classification because our next topic will be classification and diagnosis. So today is just looking at the pathogenesis, and this helps us to understand why the patients are treated with the various modalities that we treat, and also helps us to understand why the patients end up with the complications that we usually see them getting. So for type 1, the first one we have is usually called type 1A, and it's an autoimmune type 1 diabetes. So what happens is that the beta cells that usually produce insulin in the pancreas are produced by an autoimmune system. The body produces antibodies against the beta cells that destroy them. And this is usually in genetically predisposed people. And they produce islet cell antibodies that eventually destroy the beta cells. And once the beta cells are destroyed and reach a critical level, then the patient presents now with the hyperglycemia, and they present with the classic features of diabetes. They have different markers. These patients will have different markers of immune destruction due to those islet cell antibodies. And the commonest marker we get is the glutamic acid decarboxylase, that is the GAD65, that is found in 85 to 90% of the patients. Unfortunately, most of these tests are usually expensive, and that is where you find most of us who are practicing in low-income facilities or low-income areas, we are not able to tell our patients to do these tests due to the lack of finances. And we find that these tests ideally should be done in patients before they start insulin, because once they start insulin and have been on insulin for more than 2 weeks, they do develop insulin antibodies. These patients also often present with other autoimmune disorders, and these include disorders like thyroid disorders like Hashimoto's or Graves' disease, or adrenal disorders like Addison's disease. So we usually advise for these patients with features of type 1A diabetes to also screen for other autoimmune disorders. Other triggering factors have been suspected, like viruses, which include mumps, intrauterine rubella, Coxsackie B, cytomegalovirus, and echoviruses. Environmental factors have also been thought to have to be a trigger factor. Viruses seem to cause direct invasion or are associated with triggering an autoimmune response so as to destroy the beta cells. Other chemical substances have been found when they do studies in animals to cause destruction of the beta cells. And these include things like nitrosamides or alloxan that can be found in smoked meats. And that is why we commonly try to tell our patients to avoid preserved or processed foods. Another type is a 1B, which is called idiopathic type 1 diabetes. And in these patients, there's no known etiology. And these patients have a permanent insulin deficiency, that is insulinopenia, and are prone to ketoacidosis. Remember what we said is that when you do not have insulin, what happens is that the cell is deficient of glucose because it's not able to uptake the glucose into the system. And therefore, the body looks for alternate sources of energy and breaks down lipids and amino acids. And those ones have byproducts, which are ketones and hydrogen. Therefore, ketoacidosis occurs. Type 1B seems to be more common in our African and Asian individuals. And some patients seem to have periodic absolute deficiency of insulin, where they keep developing ketoacidosis. So these are the patients you keep finding. They are admitted very frequently for ketoacidosis. Some of the studies that have been done have found that prolonged breastfeeding seems to protect patients from developing type 1 diabetes. And it has been postulated that early exposure to cow's milk to the infants may predispose them to developing type 1 diabetes. So what about type 2 diabetes? Type 2 diabetes is different from type 1 diabetes. And that is where you've seen for our patients with type 1 diabetes, because they lack insulin, then the treatment of choice and the ideal treatment for them to be able to survive and thrive is administration of insulin. So when we find patients with type 1, please do not give them orals. Please do not feel sorry for them. Give insulin because that is what they need to survive and thrive. What about type 2 diabetes? Type 2 diabetes, the exact pathogenesis is not known and has not been identified, but there are very many, several predisposing factors that have been associated. One, people who are more than or equal to 40 years of age, and that is why when you request these patients to go for medical checkup, a blood sugar should be part of the medical checkup. If the patient has got a first-degree relative with diabetes, patients who come from high-risk population, and high-risk population are Africans and Asians. For Africans, we look like our genetics are for hunters and gatherers. So when we given excess in terms of the food that we eat is not what our genetics was commonly used to, we are at a high risk of getting severe diabetes and severe hypertension. And that is why you find some patients are diagnosed with diabetes or hypertension, and in several 3 to 5 years, they seem to have gotten all the complications that you can think of. It's because of our genetic predisposition. If a patient has got a history of impaired glucose tolerance or fasting glucose impaired, that is a history of pre-diabetes, patients with other vascular diseases, patients with history of gestational diabetes, which is very common, history of delivery of a macrosomic, that is a baby who's more than 4 kilograms, patients who are overweight or obese, people who are physically inactive, which has become very common, including even in the rural setup due to the boda bodas, the small motorbikes that take people everywhere, and healthy diet due to the kind of lifestyles that we live. We don't have time to prepare proper meals. Therefore, because of a fast lifestyle, you find that fast meals are very readily available and easy to get. Excessive alcohol consumption, stress, especially currently when we have this pandemic of COVID, people have lost their jobs, people are, there are all manners of stresses that have been associated, and chronic use of steroids. All those are possible risk factors, and when you have these risk factors, the patient is at risk of developing type 2 diabetes. So type 2 diabetes is thought to arise from insufficient insulin production, insulin resistance, even when they produce the insulin on the peripheral cell level, that is the cells that take up the, which have receptors, that is our liver, our skeletal muscle and adipose tissue. And most of the time, these two factors are combined. So insufficient insulin production results from impaired insulin secretion and also from beta cell malfunction. The impaired insulin secretion can result from loss or destruction of beta cell. As we grow older, we progressively lose our beta cell function. And this is more so in patients who are genetically predisposed. Also, patients who get inflammation of the pancreas, either to different drugs or alcohol that can give them pancreatitis, will cause loss of beta cell. And these patients who get pancreatitis and develop diabetes, because they will have absolute loss of the beta cells, then these ones have to be treated with insulin. Another one is we find that islet amyloid peptide is usually co-secreted with our insulin, and that can end up being deposited in the beta cell, and eventually that causes our beta cell to be destroyed. Now, with our patients with type 2 diabetes, about 7% of their beta cell function is lost each year. And with that, it tells us that type 2 diabetes is a progressive condition, and the insulin deficiency will worsen over time. So what we usually request when you first meet our patient is to never use insulin as a weapon to try and make your patient to be compliant. Do not tell your patient that if you do not use your drugs well, we will have no option but to give you insulin, because the day that they require insulin, then they feel like they have failed. And we tell our patients, the longer you live with your diabetes type 2, the chances are very high that you will require insulin, because it is a progressive condition. And impaired insulin secretion, we find that insulin requirements increase as part of the normal aging process. The aging process results in the loss of beta cells. And what happens is that when the blood glucose levels will rise and exceed the insulin production, your insulin requirements exceed insulin production, we get at a point where we call primary failure. And this is when now we are able to diagnose the diabetes. And in some of these people, it does not occur until very late in life. And you find that the patients, most of them who are diagnosed with diabetes, unless the ones who do frequent tests, they have lived with a pre-diabetic state for about 5 to 7 years before they know that they have they live for about 5 to 7 years before knowing that they have diabetes, because they had not reached that primary failure. So you find our beta cells start coming to a loss, and we start losing 7% each year, and it is progressive. And as our insulin requirements are increasing, we get to a point where insulin requirements are more than what our endogenous insulin production can cope. So you find at this point is when our patients present with our polydipsia, polyuria, they have weight loss, and at this point they present to the clinician. But it doesn't mean that at this point they had normal blood sugar. It's just that they had not presented because the body is still able to sustain them. Beta cell malfunction also presents with incorrect secretion patterns. Remember, we said that we have a fast phase that is short, and the fast phase release of insulin is deficient in some patients who have type 2 diabetes. And these patients will present with an elevated postprandial blood glucose levels. These are the patients who, when you check their fasting blood sugar, it is normal. But if you check their blood sugar 2 hours after a meal, you find it is elevated. And that is why when you do a fasting blood sugar and you do maybe a HbA1c, and if you're not too sure what is happening, an oral glucose tolerance test is usually ideal for us to be able to know whether the patient truly has diabetes when the values are not too clear. Beta cell malfunction can also come due to other abnormalities that impair the insulin secretion, including abnormal amounts of inactive insulin being secreted and the amyloid deposits which congest the beta cells, and therefore you're not able to produce the insulin. So this beta cell malfunction is usually slow but progressive, and eventually you find our patients do require insulin. Now, what about insulin resistance on the peripheral cells? That is insulin resistance on the muscle, on the liver, on the adipose tissue. This occurs due to unclear reasons and is very common in patients who have central obesity. That is, their abdominal girth is elevated. That increases the patient having insulin resistance. And what happens is that there's reduction of glucose uptake by your muscle and your fat, and there's reduced glucose storage as glycogen in the liver. Therefore, insulin resistance in the fat cells will result in reduced uptake of fatty acid and increase in breakdown of lipids, and can eventually lead to ketoacidosis. What are the implications of insulin resistance? What happens is that in many insulin resistant states, you have a decreased insulin clearance, and the number of insulin receptors on the cells are often down-regulated. And remember that because we have insulin resistance, the glucose is not able to be taken up by the cells. Therefore, you have an increased level of blood sugar in the system, in the bloodstream, and therefore the blood glucose was the strongest stimulus of insulin production. So the pancreatic beta cells try to secrete more insulin. Eventually, you find that your patient is in a state of hyperinsulinemia due to that insulin resistance. So what happens? In our patients who have diabetes, you find the blood glucose is elevated because in our muscles, the blood glucose uptake is reduced and the proteins are broken down to amino acids. In our liver, the glucose uptake is reduced, and therefore the glucose conversion to glycogen is reduced, and you find that you're making more glucose from the amino acids and fatty acids. And from the fat cells, the triglycerides are being broken down to fatty acids. And at the end of it all, you find that you have an imbalance and you have an elevated blood glucose. Patients, what is the implication of the insulin resistance? Is that our patients will have a marked degree of hyperinsulinemia to be able to maintain the normal blood glucose. But as the beta cell function continues to decline and the patients are not able to produce enough insulin to be able to overcome that tissue resistance, then at some point, now they appear with the clinical diabetes. So in conclusion, type 1 diabetes results from mostly an autoimmune process and results in progressive beta cell destruction, and therefore the patients require insulin to live and thrive, to survive and thrive. In type 2, you find that the patients have insulin sensitivity, which is relative and not absolute like type 1. It is a progressive condition, and in most patients, within 5 to 10 years, because of that progressive loss of your beta cells, you do require the insulin. Thank you.
Thank you very much, Tari. Over to you, Ken, in terms of guiding us on the question and answers. Thank you.
Thank you very much, Dr. Wanjiru. That was really, really, really enlightening. Very, very good presentation with a lot of information, and I'm sure everyone who's listened very keenly is much the better that they listen to you. So thank you very much. At this point, we'd like to welcome any questions. We had requested that if you had questions, you place them on the chat. We don't see any, but if you could just quickly post questions there, and if you feel you need to ask it by speaking it out, then just use the raise hand function, and you'll be unmuted so that you could ask your question. We have just about 8 minutes for the question and answer session.
Ken, there's one question from Winnie who asks if there are any special protocols, specific management protocols for pregnant women with diabetes and postnatally.
Thank you, Winnie. That's a very important question due to the increased number of gestational diabetes. So for pregnant women, we suggest that they do get an OGTT at from 24 to 28 weeks. And the treatment of choice is usually insulin. When, of course, insulin combined with lifestyle changes. When a patient is not able to use insulin or not comfortable, then the next best choice is usually metformin, but the guidelines discourage use of metformin due to other associated complications and even putting the unborn fetus at risk of developing diabetes later. So the choice is usually insulin. But if you can't, you use metformin. In other setups where the patient declines use of insulin and metformin is not adequate, studies have shown that glibenclamide is the only other one that you can use. So it is insulin first, together with lifestyle. Then if not possible, then you can do metformin. And if it's not working, you can add glibenclamide. Now, I think there will be a session on just gestational diabetes and treatment, because there's more details. But that's for as an introductory.
Thank you. We have a question from Mosima Nyabocha, who asks, his question is, people with type 1 diabetes, at what level do we initiate insulin?
So patients with type 1 diabetes, as I've talked about the pathogenesis, is that initially it is a progressive destruction of the beta cells due to mostly an autoimmune process. So initially you might find that you start them on insulin. Once they present with hyperglycemia, you start them on insulin. And the best regimen is a basal bolus. We don't like premixes in type 1s because it will not mimic the normal physiology I talked about of production of insulin. Now, some patients, because they still have some preserved beta cell function, they go into what we call a honeymoon period, where they start going into hypoglycemia because the glucotoxicity has reduced because of the introduction of the insulin, and they have some insulin they're producing, so they go into hypoglycemia. So what we usually advise these patients is that we don't know how long the honeymoon period will last, so we stop the prandial insulins, but maintain the basal insulin at a very low dose. Even if you're going to use 2 units, it is important so that the patient is aware that their diabetes has not gone away. In patients who get very sick, we also tell them that please, they should not stop their basal insulin because they're at a very high risk of going into DKA. So immediately you diagnose the patient, please start them on insulin. Thank you.
There's a question from, another question from Mosima. Diabetes is a chronic condition causing the deterioration of one's immunity. Is there a need for us to also screen the same in our TB clinics as an opportunistic infection?
Sorry, good question, but I don't get, we screen for diabetes as an opportunity or screen for tuberculosis.
Or, I believe it is, he says diabetes is a chronic condition causing the deterioration of one's immunity. Yeah. So with a reduced or a compromised immunity, is there a need for us to also screen for diabetes in our TB clinics? I'm not quite clear on this. Yeah.
Yes, I think it's important for anyone who's at risk should be screened for diabetes. The other thing is that some of our patients who have tuberculosis also have retroviral disease. And some of the medications, including the protease inhibitors, put the patient at risk of developing insulin resistance and diabetes. So those are patients who should be screened. Patients also who are attending psychiatric clinics and on antipsychotics, the olanzapine and the like, should also be screened. Patients who are post-transplant and are receiving steroids or tacrolimus should be screened. Thank you.
Can I request that we go to the case presentation? There'll be another brief sessions of questions and answers after that.
Okay.
Over to you, Dr. Wanjiru.
Okay, so I'll do thank you. I'll do 2 case presentations, and this is just to highlight the pathogenesis, what we have just learned. When we look at these patients, we're not looking at what exactly the management, but we're trying to look at why did that patient develop that, and could have this been picked earlier. So the first case is a 15-year-old male patient who had recently joined secondary school, presented to the casualty department with a 1-week history of polyuria and polydipsia. But the main reason why he came at that time is that he developed sudden onset of severe abdominal pain that was associated with vomiting. He had no cough or shortness of breath. The family denied any history of chronic illness or known family history of diabetes or other family history of chronic illness. He did not, was not known to ingest ethanol, other supplements, or other herbal medication. When he was triaged, the main thing is that his blood pressure was low at 80/45. He had a tachycardia of 112 beats per minute, which was regular. He had a normal temperature of 36.7. His SpO2 was 95%, and in this era of COVID, we usually are very clear on finding about the SpO2. His weight was 45 kilograms, which gave him a low BMI of 15.2. His random blood sugar was rather high at 24 millimoles per liter. The key clinical examination findings is that he was markedly dehydrated. He had no jaundice, pallor, or edema. He had Kussmaul breathing, that is your acidotic short breaths. And his abdominal exam just noted tenderness, which was elicited on the epigastrium, but no organomegaly. His Glasgow Coma scale was reduced at 11/15 with a verbal of 3, eye opening of 3, and motor of 5. But the other systems were essentially normal. At that time, the diagnostic formulation was, this is a patient who probably has diabetic ketoacidosis in a newly diagnosed type 1 diabetes. And the reason at first we thought about this is that the random blood sugar was 24. This is a patient who looked to be acidotic due to the rapid shallow breaths, Kussmaul breathing that we call. And he came in with severe abdominal pain. And unfortunately, in some of these patients, they end up going to theater because people think that they have an acute abdomen. So we went ahead and secured his airway, breathing, circulation, and started 2 wide bore cannulae. You saw that his blood pressure was down, and drew blood samples for a blood count, the kidney function, a TSH, a blood culture. And if you're in a facility that can be able to do serum ketones, you can do that. And nowadays they have glucometers that can look at serum ketones. A urinary catheter to monitor his urine output was inserted, and a specimen was taken for urinalysis. Because of the low GCS, there was fear of possible aspiration. So an NG tube was inserted to protect him. And he was immediately commenced on intravenous fluid, and later on intravenous potassium infusion and insulin infusion was inserted. His blood workup noted that the white blood cell count was elevated at 16, but the other counts were normal. He had deranged renal chemistry with an elevated urea of 16, a low potassium of 3, a sodium of 145, a creatinine of 200. His arterial blood gas noted he was acidotic, metabolic acidosis with a pH of 7, a PCO2 of 28, and a bicarbonate of 8. His urinalysis showed that he had ketonuria 3+, glucose of 3+, and nitrates were negative because we know UTI could be one of the triggering effects. His blood culture eventually came back with no growth after 72 hours. His thyroid function screening was normal, and his HbA1c was elevated at 12%. So our final diagnosis became that this patient has got diabetic ketoacidosis, has got acute kidney injury, and type 1 that was diagnosed. So remember, this patient is insulinopenic, therefore his cells were not able to use up the glucose, so the glucose went up. And because the cells are energy deficient, they broke down the lipids and broke down fat cells to produce energy, and that gave the patient ketones and hydrogen, therefore putting the patient in a ketoacidosis. Because of the polyuria that he had before, he ended up having acute kidney injury due to the dehydration. So that pathogenesis tries to show us how these patients present and why we require the treatment that we give. So the non-pharmacological care is that we need to protect the patient from aspiration, that's NG tube insertion with 2-hourly turning. Diabetes educator and counselor needs to come in early. This is a young patient. Nutritionist review also needs to come. And the educator and counselor is important, especially in our setups where most people think that they have been cast or someone looked at them badly. So they need to understand that it is not their fault, but something that no one was in control. The medications we gave was intravenous normal insulin, normal saline infusion. Potassium is very important due to the low potassium, and insulin infusion usually causes the potassium to go down. Remember that these patients are prone to getting deep venous thrombosis. Therefore, prophylactic enoxaparin or heparin is given. Prophylactic antibiotics should be commenced, but if you have a facility with cultures, and in our facility where our growth was negative, we stopped them after we got the cultures. Proton pump inhibitors are also important due to the stress that they get. On further review, a venous gas is done. In our further series, we'll find that we don't need to do arterial blood gases subsequently. You just need venous gas for follow-up. And the pH was 7.2, bicarb was 12, potassium was 3.5. Management was continued, and within 24 hours, his DKA had resolved. He was able to eat. His GCS was 15/15. Bicarb was 18, pH was 7.5, and the patient was converted to a basal bolus regimen. Education and counseling, very key, was continued. So our second patient is a 42-year-old female who was referred by a gynecologist due to history of general malaise and recurrent vaginal candidiasis over the last 3 months. She reported history of gestational diabetes 5 years prior during her last pregnancy, and she delivered a healthy, bouncing baby, 4 kgs. During her pregnancy, she was treated with metformin and diet and was not followed up thereafter. She had a strong family history of diabetes in her mother and 2 other siblings. She led a sedentary lifestyle, did not partake alcohol or smoke cigarettes. Her BP was elevated at 150/90, normal pulse of 88. Her BMI was quite elevated at 38. Her random blood sugar was 14. Physical examination found a middle-aged female, no pallor, edema or icterus, no thyromegaly, central obesity on abdominal exam with an elevated waist circumference of 106 centimeters. Other systems were essentially normal. So initially, we thought that this patient just presented with vaginal candidiasis, newly diagnosed type 2 diabetes, and with obesity. Clotrimazole pessaries were given, diabetes education and counseling, and she was very, she was not accepting that she could have diabetes. Nutritional advice was also given, and she was commenced on a low carbohydrate diet due to her elevated BMI. HbA1c came back at 9.6. Thyroid function test, TSH was 6, with normal FT4, FT3. Kidney function was creatinine ratio was done. It was elevated at 68 milligrams per gram. Lipid profile noted that she had elevated cholesterol with a total cholesterol of 7, LDL of 3.8, HDL of 1.2, and a triglyceride that was elevated at 2.9. Her other investigations, blood count, liver function, were essentially normal. So we changed the diagnosis that this is a type 2 diabetes with microalbuminuria. She also had subclinical hypothyroidism due to the elevated TSH and normal FT4, FT3, with mixed dyslipidemia with an elevated LDL and an elevated triglyceride. So non-pharmacological care is a nutritionist review, physiotherapist review, diabetes education and counseling, and she was also sent for retinal screening. Eventually, after a lot of counseling, she accepted to commence on medications, and she was commenced on drugs that have cardiovascular benefits, that is the empagliflozin, and the initiated, and antihypertensive in the form of telmisartan was commenced. She accepted her diagnosis and medication, and eventually enrolled in a 12-week program of a diabetes reversal program. And she lost 10 kilos in 3 months. And on her review, she was very elated. She felt better, and her HbA1c had reduced from 9% to 7%. And she continues with the, the diabetes reversal. Her main aim is to lose more weight and see whether she can come off the medication. So this is a patient who you can see had very many multiple risk factors. She led a sedentary lifestyle. She had gestational diabetes. She's got family history. She's above 40 years. She's obese. So all those multiplicity of factors then put you at a patient who should have been screened, and eventually on screening has the diabetes. Thank you.
Wow, that's good. That's heavy, very, very informative. I'm going to ask for any further questions, if we can have any further questions, and especially after that, those two case presentations. If you have any further questions, we could ask Dr. Wanjiru to answer them. Just post them even as we attempt the quiz a second time. Let's attempt the quiz. It's the question we just got, the beautiful position. Let's see if we could answer it again.
Yes, you're all encouraged to attempt the quiz. No prizes given today for getting everything right, or it's really just to help you to test your knowledge. Thank you.
Kindly answer the questions. Please, let's all attempt the quiz. We only have a few people who have begun the quiz, and we have just another 3 minutes to the end of the quiz. Another 2 minutes. One minute.
There are people who have noted on the chat that they are unable to see the quiz. Our technical team is trying to identify what the problem could be. I think this is something that we need to look at, because right now, the majority of people on the call are able to see the quiz, but there are a few who cannot. Sorry about that.
Okay, that should be it. I can't see any more questions on the chat. Yes, I can't see any more questions in the chat, so I will.
Sorry, Ken, I think there is a question. Let me just get it. There's a question from, hello, can you hear me? Hello?
Yes.
Yes, we can.
Yeah, the question from Dr. Elizabeth Ogaja, and welcome, Dr. Ogaja. Dr. Ogaja is one of our subject matter experts in pharmacy, the pharmacist. He says, what are the main challenges of managing diabetes programs in the rural areas, especially post-COVID-19?
Thank you, Dr. That's a brilliant question. And that's even if it's not only in the rural areas, but even in the urban areas, but maybe the rural areas might have been more affected. That we found, like in a scenario like Kenyatta National Hospital, we get our patients from everywhere. And we found that because there were lockdowns, and initially we were very scared about COVID, we had told the patients not to come to the clinic unless absolutely necessary. So when the patients started coming back, they came back with multiple complications. If it was like a wound that could, the wound could have been salvaged, we are finding that we had to amputate. If it is like kidney injury, you find that they have gone into chronic kidney disease and they probably need dialysis. Most of them were very fearful of coming to the facilities. Most of our patients also lost income either they're dependent on their dependents who are in Nairobi and they stopped their medication. So that was a key thing that we found. And we were, at some point, that's why the MOH started saying that the patients with chronic illnesses should attend their clinics as usual, because they were told not to attend, and therefore they really complicated. So we hope that we pray there'll be no other pandemic, but we're able to manage these patients in a better way. So some are coming back, but unfortunately they're coming back with complications.
I can see Dr. Ogaja, nodding and smiling. So I believe the question has been well answered. Thank you. I do not see any other questions. So back to you, Ken.
Thank you so much. I will ask for the results of the poll to be posted for Dr. Wanjiru to take us through those before we end this session.
So we'll go through the questions. And the first question was, what are the actions of insulin? And when I was looking at it, I thought maybe I should have phrased it better. And the majority said that it assists in metabolism of glucose, and that is true. It assists in metabolism of protein, that is also true. Assists in metabolism of fat, that is also true. The answer that's not true is none of the above, and I think the 41% wanted to answer that it assists in metabolism of glucose, protein, and fat. Now, the second question is lack of insulin. Where is it? Yeah, what does lack of insulin lead to? Remember, we said lack of insulin will cause your glucose to go up, and you'll be able to, what will happen is that you will end up using the other energy sources, which will give you acidosis. So lack of insulin will give you hyperglycemia and not hypo. And therefore, the correct answer is diabetic ketoacidosis and hyperglycemia hyposmolar state. This will come later, but it does not cause hypoglycemia. It causes hyperglycemia. What is the pathogenesis of type 1 diabetes? Is it an autoimmune disorder? Is it insulin resistance? Is it due to obesity? Or is it due to lack of exercise? Remember, we said there's type 1 and type 2. Type 1A and type 2. Wait a minute, I think I've lost the question. Pathogenesis of type 1 diabetes is due to an autoimmune disorder. They have an idiopathic that it was not in this answer. Then pathogenesis of type 2 diabetes, is it an autoimmune disorder? Is it viral infection? Is it a combination of insufficient insulin production and resistance, or bacterial infection? And majority got it right. It is because it is a combination of insufficient insulin production and insulin resistance. Patients with type 2 diabetes, they first do not require insulin and eventually require insulin. We said that if you live long enough with type 2 diabetes, because it's a progressive disease, you do require insulin. Then the last question was, the following hormones are referred to as counter-regulatory hormones. That is the hormones that are produced when your sugar is down. That is when you have hypoglycemia, or what we called if they're insulin antagonists. So it cannot be insulin. So it is cortisol, that is true, growth hormone, and glucagon. So B, C, and D. Cortisol, growth hormone, and glucagon. And the glucagon is the one that initially is when you have low sugar, comes out fast. So you did well. Thank you.
Thank you very much, Dr. Rosemary. I think our time is up. There's a question that has just come in from Dr. Lucas Nyabero. Maybe you could just give it a quick answer, as to what's the availability of blood glucose testing kits, in the country for patients, and are they affordable? You know, is there any social support? Are these covered by NHIF as far as you know?
That's a very good question, because especially our patients with type 1 diabetes, you need to have self-monitoring of your blood glucose for you to be able to have good controls. Unfortunately, they are not covered by NHIF. They are not sold in most public hospitals, including Kenyatta National Hospital. So the patients incur a huge expense, and not even for the glucometer, for the strips. So KDSG, that is Kenya Diabetes Study Group, we have an advocacy group that has been fighting and putting forward to the Ministry of Health that they need to remove the VAT on these items. So we are getting somewhere, and we are hoping. The strips have been coming down. Initially, they used to be like 3,500 for a pack of 50, and now most of them are 2,500 and below. So they are coming down, and we are hoping that with more advocacy and with teams like CDMS and other organizations, we're going to be able to give our patients the glucometers. Sometimes you have to work with companies, and when you're having the World Diabetes Day, you request them if they can give clients free glucometers, and that has worked for Kenyatta National Hospital and some private facilities. You find you get free glucometers, so more advocacy is needed.
Thank you very much. I think we'll use your slides. Just go to the next slide for us, please, Terry. Ken?
Yeah, thank you so much, Dr. Wanjiru. Thank you for all the participants, everyone who's been able to log in tonight and participate in this very, very informative session. As you can see on your screen, our next event will be on Thursday, the 24th of March, 2022. That's in 4 weeks' time. The topic will be classification, presentation, and diagnosis of diabetes. Classification, presentation, and diagnosis of diabetes. We urge you to attend, keep time, and bring a colleague along, because we never know who is going to benefit from this. So thank you very much. And if you have any topics you'd like us to present in the future, feel free to post these on the chat before you log off. You can also share them on our social media pages. Once again, these are our social media pages.